give me a minute to fix my slides.
So I have to give Holly a minute to fix her slides. So really, really great. So that brings us to the end of our sharing of good practice and alternative ways of addressing issues that we all face. Holly now is going, we've got 2 activities left. Holly's going to do her bit as the audit manager to give us an insight into what we're going to be doing with the audit going forward. There's 1 or 2 questions being asked of us about data and data submission, particularly around the hybrid closed loop. Fulia's probably on her way out, but she's briefed us both, I think, so between us we can get through that. But we'll hand over, and then we're into a group session before we disappear out the door home. Over to you.
Thank you. Sorry. Okay, so I'm going to talk as briefly as I can about what we've been up to since we last saw you last January at the Regent's Park, Bloomsbury Inn, and then tell you a little bit more about what's happening next year, and then leave some time for questions, because I think there are suddenly a lot of questions around quarterly reporting and HCL, which, if we'd known about the HCL thing sooner, maybe we would have built more of a session on this, but the pace has been really frenetic, so it's kind of great to have an opportunity to find out from you where you are at and what your anxieties are at where your anxieties are around our reporting, because some of them are shared by us, so we can work through it all together and it'll be all right. So it's been a really busy year since we last saw you. We've published quite a few annual reports, including our hospital admissions report. So this looked at 5 years of data between 2015 and 2020, and it really demonstrated that despite the really amazing improvements that we've seen in HbA1c, like the other complications, the macro and microvascular complications that Justin covered in his presentation earlier, we've not seen the reduction in admissions that we would expect. The trends haven't followed. So clearly, an additional approach other than just focusing on HbA1c and assuming that will fix admissions is necessary. And one of the benefits, I think, of more frequent reporting in the public domain and really focusing on DKA as an outcome measure, as a quality indicator, hopefully that can catalyse those efforts. So we published our State of the Nation report and the extended analysis on our 2021 and 2022 data. That showed that continuing increase in incidence of type 1 diabetes further to the start of the COVID-19 pandemic. There was a question in the chat, I'm not sure any of you saw it, well, you wouldn't have, those of you in the room. Was there regional variation in incidence? Yes, there was. We introduced a heat map, for instance, because Neil Hopper on our dataset and methodology group, he's like, I'm sure we're getting absolutely hammered in the northeast compared to others. And we did a heat map, and yes, they were. And so there are regional variations in that. So please use your data to support your conversations with people in your ICB who can potentially be called upon to help with staffing, to help you manage the increasing numbers and the increasing complexity. So this week we disseminated your unit level reports on the 2022-2023 analysis. So hopefully you've all had an opportunity to at least skim your results from that year so far. Killian, NPDA analyst over here in green, he's done an amazing job to turn those reports from something that was created in Excel with 1 million different macros into simplifying things in R, which hopefully means that we can get those reports out within a couple of months of you submitting, well, after us validating the data. I'll get to that in a minute. So you're going to get your gold standard core audit annual results quicker next year, which is fantastic. We collected the first year of care PREM dataset, and we were absolutely delighted with the response. Thank you so much for all of your efforts to target your eligible patients. That was on our risk register. We weren't sure how that data collection was going to go. We know that the PREMs are really well supported when you can just approach anyone coming into clinic to complete a survey, but this involved an extra layer of proactivity, identifying those eligible to complete a survey, and you absolutely smashed it well beyond our expectations. So it was on our risk register. Would we be able to do unit level reporting? We think we will, because most teams have collected the minimum amount of responses, and we've got a really meaningful national data set as well. We haven't cleaned it yet, we just downloaded it and totted it all up, but we're looking at a response rate of around 40%, I think, of all eligible patients, 40 to 50, which is actually amazing, really good. I think we've got something like 2,400 responses, and if you think that 4,000 children and young people will have been eligible to complete a survey in that time, that's amazing, well done. We finally finalised the type 2 diabetes spotlight audit data set. I wasn't really expecting that to take so long because it's a re-audit. Those of you who were around a few years ago will remember the type 2 spotlight audit we did before. This is a re-audit, but things have changed, things have moved on, and we wanted to make the collection more easily completed by those on your teams who might not be able to interpret the results. So we can interpret the results for you, which should lead to better data quality. Commissioning the Association of Young People's Health to do that report they presented on so brilliantly earlier. And we've facilitated a number of data access and information requests, including support for the technology updates within NICE guidance, including the justification for including closed loop systems. So that has just really snowballed, as you know. So what's coming next? Well, on Monday, I think it is, or Tuesday, we are submitting our extension proposal to our commissioners, HQIP. So we are funded for 3 years, and then we are offered an extension for 2 years on that contract, if we want it. I think we do, before we go out to a competitive retender. Don't worry, Fiona, it's not like we never not consider it. Yeah, so as part of that process, our commissioners ask us what we'd like to do over those additional 2 years. And what we've said, or what we will say when we put in that proposal, is that we would like to build on we'd like to refine our quarterly reporting. You know, this is going live in April. It's going to take a while for everyone to adjust to the reporting. We're going to figure out where the data quality issues lie. Are some metrics better completed than others? Is some of it going to be junk data? We don't know at this point. We won't know until you've submitted the data and it's embedded, which it will. But we'll be making refinements. We'll be making it easier for you to review your data in advance before you submit it. We'll also be reviewing the NPDA core data set. We typically usually do that when NICE guidance is updated because, of course, we have to audit against standards. But there are certain data items that could improve the quality of our data set or the data collected. So, for example, at the moment, we're asking you, was the patient in DKA when they were diagnosed? Well, we'll probably be asking you to supply the pH as well because discussions with our international colleagues, like Reinhardt, have suggested that actually when they look at the pH of patients submitted who are recorded as being in DKA, they absolutely weren't. So there's little tweaks that we can make, but nothing that's going to make the data collection too onerous for you, which is always uppermost in our minds, don't worry. And then the main sort of flagship project over that 2 years, we're hoping to do a service level audit, which will build on the workforce audit that we published in 2021. So we've been publishing that minimal staffing data set, but that's for you. That's not a commissioned product. That doesn't go to policymakers. It's not subject to the same validation. So we are aware of the increasing numbers with diabetes, of course. We're aware that numbers of staff are reducing. So we really need to get a national picture of that. But also build on that, because in the interim we've had the psychology standards published, so that offers an opportunity to collect some better data around psychology provision in services nationally and understanding variation around that. And also transition to adult services. The NICE guidance around transition has been updated, and we've got national standards that we should be looking at as well, so that hopefully we can build more of a picture of why we still see so much variation in clinic performance, considering there's the same tech and the same drug. So we've got the type 2 diabetes spotlight data collection and reporting coming up this year as well. We were hoping to roll that out towards the end of February. That might be a bit complicated, which you'll understand when I get to the staffing update. The data collection for 23, 24 and reporting. So you will know, or maybe you are aware, that the deadline that we've given for submission of the core audit data set is at the end of May. Typically, we give you a 2-month grace period at the end of every audit year to finalise, refine, perfect your data before we take it through to analysis. We'd like to reduce that gap as we get used to quarterly reporting, because the quicker that we get that data in, the quicker we can start cleaning it, validating it, reporting it, and then you'll just be happier and you won't be saying, oh, our data's out of date. We'd love to bring that deadline back, but also we have to respect that this is the cycle that you're used to, and there will be a transition, and that's okay. But we are aware that in the framework for the hybrid closed loop strategy that came out on Monday, we're aware that you've been given a deadline of the 29th of March to submit your data, which has obviously resulted in some questions for us and some questions from us to NHS England. We've had some really constructive conversations about that this week. If your data is in the system and is complete up until the 31st of December by a deadline that we will think about carefully and communicate to you as quickly as we can, that's fine. You don't have to have your entire audit data set for the 2023-24 audit year in there on the 29th. That's 2 months earlier than the deadline you've been given. That's not reasonable. So we have got assurance that as long as your data is up to date, so who was on HCL by the 31st of December, hopefully that is acceptable. As I said, and as I understand, this process of getting through this funding, getting through this agreement, it seems to have happened in about 4 weeks, I think, from the outside. So we're all kind of learning what's going on at the same time. So in the communication we put out this week, if you got that email, we spoke to NHS England and we said, well, can we work together to produce an FAQ sheet, because you're going to have questions, we're going to have questions, so if we can work together with NHS England policy team colleagues, we can come up with something, because at the moment you're going to ask us stuff and we don't know either. I'll take questions at the end if that's okay. So our quarterly data dashboard will go live by the end of April, and that will be complete with data up until the 31st of December. So that's been communicated, and that's why we negotiated that with NHS England. We will be analysing the first year of care, PREM, and reporting that. That report will be published in October, and you'll get your unit level reports then as well. And then we'll be doing QI and engagement activities around emerging findings and recommendations coming out of those reports. So one thing we've got coming up from the AYPH report that was presented on earlier, we picked out that finding that young people and their families are just being exhausted by continually having to communicate their needs or what it's like to live with the condition at school, in the community, amongst their peers. So we're commissioning DigiBeat to create some content where we can ask families and young people what they wish people would know, how can they be easily and best supported, what conversations do they not want to keep having, so that we can create some shareable content and hopefully they can just ping that out on WhatsApp and hopefully reduce the burden. So yeah, we like to keep money aside to do little things like that as findings emerge, and we can be a little bit creative and responsive. So that's it for next year. So before I get on to questions, I just wanted to say just a massive thank you. Firstly, for the organisation of the day. Tasha has taken the lead on most of the coordination for the day, and it's actually Tasha's last full week in post. Tasha's leaving us after a couple of years to take on another exciting role in the college. So thank you so much, Tasha, for all your help to the audit. That reduces our full-time staffing team by 33.3%, so I'm just going to apologise in advance for my delayed response to your email. I'd also really like to thank the live streaming team. It's really nerve-wracking doing any kind of conference, and especially a hybrid conference, because you're worrying about people in the room, you're worrying about people joining online, and these guys just make it so relaxing. I don't know if you're relaxed, but I felt quite good today, so thank you. Thank you so much. The wider NPDA team at RCPCH, Killian's being very quiet today. I think I'm going to make him do a presentation next year. Maybe he can do Justin's presentation. You keep threatening that, don't you, Justin? I'll get to that. Yeah. So, Killian joined us, a year ago, just over a year ago, and he has not had a chance to breathe. It's been national report after national report. So it's been an absolute baptism of fire in the NPDA data collections, the various ones. So it's great to still have Syra in the team, who was the previous NPDA analyst and now helps us out as the senior analyst on the team. So thanks, guys. And where's my manager? Calvin, are you still here? Has he snuck out? Well, I thank Calvin as well. And obviously Justin and Fiona. Justin does himself a disservice when he credits us at the college as being the ones that do all the work. It is an absolute joy and sometimes frustrating to work with Justin because he really keeps us on our toes. He has been working on the audit since, 2010? So that's 13 years. Yeah, he's a lesson in how not to coast. He's always thinking of new things that we should be doing with the data, new relationships that we should be developing with different researchers abroad. He's just always trying to push the envelope, which is very motivating and sometimes annoying with the night before you've got to submit your report to HQIP and he wants to see 3 different new analyses. But yes, an absolute joy to work with, as are you, Fiona. Fiona, your formal role on the audit is chair of the dataset and methodology group, but I kind of see you as the fairy godmother of the NPDA as well. Honestly, it's just an absolute privilege working with the both of you. You've been terrible for my career progression. I've been in this job 8 years now, but you just keep making it more interesting and challenging. It's never the same thing. So thank you so much for everything that you do for us. And thank you, everyone involved, everyone who's come today to demonstrate commitment to learning and sharing with peers, for submitting your data. We really don't take your efforts for granted. I know you have to send us your data, but I really appreciate that you most of the time seem to do it willingly and enthusiastically with a view to using those results to do something useful. Whenever I get a new analyst on the team, I always say, I'm glad you're here and not doing something academic where maybe you'll write something and a handful of people will see it. You write a report on the NPDA and everyone's going to read it. Well, everyone should read it. It's a really wonderful clinical community to be serving. Really wonderful. And your relentless creativity in what you're doing with these young people to try and support their care is very motivating as well. So thank you so much for sharing that with us today and in our other events. The Children and Young People's Diabetes Network, I don't think that the NPDA would be halfway near as successful as it is without the support of the regional network managers, chivvying people up, offering support, the peer support structures in place. It's just a really nice ecosystem to be delivering data into and seeing things happen off the back of it. The NPDA board and dataset and methodology groups, you probably don't hear too much about them, but we've got a very dedicated group, MDT group, making sure that the data that we're collecting, the way we're reporting it, meets your needs. And they're long days. It's like a whole day every quarter, and everyone really contributes so well. It's really fun. It's fun. And I'd like to thank our commissioners, HQIP, for all the support that they provide to us. I really hope that they let us do what we want to do in our proposal. Actually, I should have. We only got the paperwork quite recently, and the programme of the day was already set up, so we didn't do any consultation sessions around this. But we are filming this. It will help us get our way when I ask it, and do you know what, I'm asking you a very leading question. I'm just going to ask it, okay? Do you think it's a good idea that we do a staffing audit looking at transition and psychology standards? Does that sound like something that would provide useful data to you? Yes! Okay, well, that's on film. So I will be cutting that and sharing that because we will be challenged on everything that's in there. So thank you so much. I'm glad we're all thinking in the right direction. Thank you to our funders, NHS England and the Welsh Government, and obviously just the families with diabetes who trust us with their data, their children's data, trust us to take it without consent and use it for useful purposes. And where's Rob? I think the hoops this man has had to jump through to access that data. I would feel so reassured as a parent, as a patient, as a parent, to know that there are these safeguards in place. But my God, like the paperwork, I wanted to comment at the end of Rob's talk. We started working together on that piece of work. Was it in 2016? 2016. Unbelievable. The amount of... When you become a researcher, you probably just think, oh, I just need to learn how to write reports and analyze data. But I think you are a leading expert now in linking data in information governance. It's so intimidating. Like we're well versed in information governance. We have Section 251 approval to collect this data without consent. There's a lot of paperwork involved. I've never seen anything like what this man has had to produce to do all the linkages. I'm not surprised it's taken 7 years and we still haven't got you the English data, but we will in a month. So, yeah, I really like understand our privilege a little bit better. We just get data every year like clockwork, and you're struggling for 7 years to get it out of us. So yeah, well done and thank you. And yeah, you should be reassured that we're only sharing it with people like Rob for purposes like that. It's really great. So that's it really. How long have we got for questions?
Well, I think we definitely need time for questions.
We do need time for questions.
Also, there is a tabletop and we must
finish
on time. So, but I'm sure Holly, I mean, just a clap to Holly, actually. Fabulous work from the audit. It does continue. I know Justin moans and groans a bit, but he'll be here next year, I'm sure. But it's really important that we see our audit as part and parcel of our everyday work. The data's there, we're generating the data, but our patients and families are actually the ones that allow us to generate and supply the audit with the data. So it's a big family event, really, getting audit. And we're always really keen to see the reporting at such a high standard. So well done. Who would like? I'm sure there must be questions for Holly. So hands. So we'll probably just power it. So we'll go 1, 2, and 3. There you are. There's your order.
And for everyone at home or in the office, I will try and repeat the question when I hear it. Okay. Yeah, I'll give an overview. Okay, so, and you can, it's a shame Fullia's not here, our NHS England lead, who could probably provide some of the details. So, right, there was a framework published on Monday. Oh, gosh, I literally just said that I would do that, and I did not do it. Clarity. Okay, right, sorry, I'm repeating the question. I've been asked a question about what is this HCL framework, what is this deadline to submit data, what is going on? Yes, so if you are a PDU in England, in Wales you can relax, I think. Justin nods. NHS England published a 5-year implementation strategy for the implementation of hybrid closed loops on Monday. So there's quite a lot in there, but to summarise, NHS England will be partially reimbursing costs of looping or provision of these devices and they will be reimbursing ICBs. Separately, there's also £60,000 available to support adoption of HCL at ICB level. Yeah, I'm getting this right. And I understand that there's some confusion around how that can be spent, and it seems that ICBs are maybe adopting their own rules around how that could be spent, but there's not central. There is central? Okay.
A letter.
A letter is circulating. And it must be, okay, who's this letter going to and what's in it?
It's the ICBs again. It's going to the ICBs, anyone in diabetes that does any...
It's going to the ICBs.
Work. There is a standard letter from Sean Crowe, who's the director of the programme, and it's gone to the ICBs, and it's absolutely stipulates what the 60,000 is for. So each ICB will get £60,000 to do two things. One is to support administrative costs to help units or the ICB collect data, because with the data on HCL use comes the opportunity for reimbursement from the centre for the use. So that's really important. That's number one. And the second reason it's important is it does give opportunity for teams or ICBs to put in some help to units for clinical time to develop resources or put people on HCL. So that's what it's for. So clinical towards HCL resources for training and admin to collect comprehensive data on utilisation.
So back to the deadline then. In the framework, there is the instruction to put your baseline data on ACL into our online portal. So we're not taking snippets of data. The methodology by which you would usually submit data to us, carry on. There's no new data set. There's no special new arrangement for submitting those data. Just upload your CSV, just enter your patient questionnaire if that's your method. So get your data in there. I mean, you can get it as real time as you want. You could be up to date now, that's fine as well, but NHS England will be taking a cut, or we'll be providing a cut of the data up until the 31st of December. We'll provide a deadline for you to do that if you haven't already done that. I know a lot of teams are already up to date, but we will provide a date by which you... 2023, 31st of December 2023. Thank you, Justin. Yes. Yeah. So then we will be able to give NHS England numbers according to those data, numbers using a hybrid closed loop system in your ICB, in your PDU. That's my understanding of what's required from us to provide to them and what we're asking you to do as well. So the same data set, the same methodology, just a deadline we weren't necessarily expecting. But whilst, this is happening very fast-paced, obviously usually we want to get well in advance of anything like that and give you notice for these things. I think we just have to recognise that this happened very quickly for a reason. There was an amount of money available, and that doesn't last very long, does it, in the NHS? So we need to spend it. It needs to get spent by a date. So it's amazing to have this opportunity finally. Like, can you imagine 2 years ago, we'd be standing on stage that some units have got 75% of their children on HCL already. Like, things have changed so rapidly. I remember was it in Birmingham in 2019, was it? And your patient came to talk to us and she was the first one on a licensed closed loop. And now we're at a stage where they're literally paying you for it. So yes, it feels a little bit uncomfortable and a little bit quick. And I'd love to be able to have given you this information 3 months ago. But it's uncomfortable, but I'm still really grateful that we are having this challenge. Mm-hmm.
I think the second reason for data accuracy is that the ICBs will get money for the actual kit. They're getting reimbursed to 75% of the total cost, and they cannot get money from the centre unless they have your activity. So how many pumps you're using, how many CGMs you're using, and then your trust, if they pay for that equipment now, will be in a good place to receive the income back from the ICB. But the ICB cannot get it from the centre unless they have our figures that are accurate. So it's in our interest for Holly to report to NHS England on utilisation, but us to report to our ICBs to get money back into your trust. Does that make sense? So one data collection set going 2 different directions for 2 different purposes. Yeah?
Yeah, and this might sound fine now, and then you're going to have some conversations with your trust management and your ICBs, and you're probably going to have way more questions. So what we've agreed with NHS England policy colleagues is that if you could send us an email with your questions, it's NPDA or RCPCH. If you just put in the subject HCL query, we're going to collate queries from paediatric diabetes units and then co-produce a document with NHS England to help you and us understand what's going to happen once you've submitted this data and we've sent it on. So we're all on the same page. Yeah.
Does that help? Yeah? Who was next? And then, yeah.
Thank you for talking about doing the staffing audit around the transition. What would be really, really helpful, and I don't know if you are planning on doing this, is more of a broader staffing audit across all the services. I'm finding it very difficult to sort of have any ring-fenced funding, and then any additional staff to match the increase in numbers and increase in tech is proving extremely difficult. It'd be helpful to have some national kind of data to link maybe outcomes and being able to get percentages on the points to sort of staffing levels within each centre, so that we can use that for the commissioning and our own trust just to prove what kind of staffing ratios look good.
Yeah. Okay, so I'm going to summarise that for people at home or in the office. So it was a comment that it would be great to collect staffing data because teams are struggling to get staffing, ring-fenced funding for staffing, even in the face of additional cases, increasing numbers with diabetes. So it would be useful to have some standards, is that fair? Yeah, and some comparable data around staffing and linking it to outcomes. We tried linking staffing data to outcomes last time we did the report, and it was disappointing we didn't, but it was a crude analysis, and we did caveat the analysis. It was crude. We looked at staffing per 100 patients and then correlated that with adjusted HbA1c. But I think we can probably do something a little bit more sophisticated now, and also take into account, numbers on tech and practice around transition as well. So yeah, I think that's a really, really helpful suggestion, and we will bring it to the dataset and methodology group to just maximise the impact of the data that we collect from you. I'm aware that the national networks, the workforce group in the national network, they've been doing some brilliant work around it. Do you want to say something about that?
So the network, we've got for people who don't know, we've got 4 aims, and one of our aim groups, 3, are working on workforce ratios. They've taken all the international evidence about who does what where with ISPAD, with ourselves, with the RCN. And I was speaking to Francesca today. Some people may have seen her, but she's been on that group. They're just finalising the right around. There has to be some context and narrative around the recommendations. And this is actually like a calculator where you would put in your patient numbers and it would spout out how many of which professional it would be recommended. It is consensus. There is nobody anywhere has this real hard data. But my plan is, once I've got it, is to take it to the workforce group at the college, because in order for this to have teeth and to influence commissioning, then we're going to have some endorsement, and we're going to try our own college to see if they'll take this on. And then our ICBs and our units will have a calculator, and then it will give you some guidance, and you can then do a gap analysis between recommended versus reality. Yeah, so we're doing what we can, but it may not influence the spend because we're competing with our asthma, our epilepsy, our cardiac, our renal colleagues. So it's up to us to use that, but then get our business case and our evidence together. And it is robbing Peter to pay Paul, I'm afraid. And remember, we have numbers, we have inequalities to address with the Core 20+5 agenda, and we've got the technology to do. So 3 hard hitters for us, and we can justify every penny of investment, and for sure. Whether we get it or not, that remains to be seen.
And we should still have some resources from the quality programme around building a business case to support more staffing. I know that was a huge focus of the programme. I'm sure there must be some case studies that could be shared from services. Yeah.
But it's on the agenda, so we are trying to address it to help everyone. Yeah. I would just hang out. I think you were next. Is that right? And then we'll come to you. Yeah.
Shout.
Hi, I'm not sure if we were outliers, but we really struggled to get the numbers for the perm survey. So I think the last time I checked, we had 9 parents, which means that we're not going to get any unit level data. Is there any way we can get any kind of unit level feedback? Maybe there's not analysis, but some feedback. Or is there any way to kind of sneak in another one to get up to 10?
Okay, I'm going to summarise the question. A clinician in the room has asked, or has noted that he's got 9 prem responses. We've put the cutoff as at 10 prem responses to get a report. He's wondering, can they sneak in any more data? No, you can't sneak in any more data. You can't do that. But it is a reasonable question to ask us, is there any way that the service can get any feedback? So I think what we're going to do is, first of all, we'll look to see which PDUs have managed to get 10, and then we'll get a PD level report. Sometimes there are more than one PDU within the same trust. If that's the case and one's going to get a report and another one's not, we can amalgamate. And then there will be reporting, but not in the same PDF way, but there will be reporting in our Excel files at regional level and probably within the national report as well. We can probably make qualitative comments. I mean, it's difficult to say because I actually haven't seen the full data set yet. I don't know what percentage at this point, what percentage of those 2,400 responses have got qualitative comments that we could maybe share or not. You know, we have to consider small numbers, and we don't want to put reports out in the public domain based on, I mean, 10 stretching it, to be honest. If I had my way, you know. What is it we were taught in psychology? Never report anything less than 30. Yeah, you're lucky you're getting 10. So yeah, I suppose to sum up, we'll do what we can to maximise the data and to reward the effort that you've put in. We're really grateful for the efforts that you've made, especially teams that, you know, don't have that many new diagnoses in a year, the smaller teams. We really appreciate your efforts, especially if you knew you weren't going to get a report. But it absolutely contributes to the whole, and meaningful things will come out of your efforts at a national level and at a regional level. So thank you. Ronald?
Yeah.
It's a question more for you.
Yeah.
We discussed about difficulties with the staffing and the resources, and one of the issues we are finding is, though there is best practice tariff, many of the units are not getting it, and it is getting lost between ICSS and the unit.
Yeah.
Is it possible to influence that nationally?
Can you summarise it and tell him? Yeah.
I spend my whole life doing that. No, I'll tell you seriously. So the question was about the ability of teams to actually get the benefit of the best practice tariff into their clinical practice. And this has become a challenge over the years, I would say. I think initially it was better, and then gradually the effect has waned. The issue we have is that best practice tariff was something, an incentivized payment for delivering quality standard care when we had payment by results as a method to reimburse units for their efforts. The majority of units across the NHS now, particularly since COVID, are on block contracts or something called an aligned incentive contract. And I have it on good authority, both centrally and locally in Leeds, that best practice tariffs are not effective and cannot be used within the current contracting system that the NHS is adopting. So my finance director was at the pricing team on a call just to articulate things from his point of view. I'd already articulated it from my point of view as a jobbing clinician. And Fulia and the central team are trying to work out a way where tariff, best practice tariff, can be once again used within block contracts. But as the financial way of refunding in the NHS stands right now, the tariffs are relatively obsolete, and we're trying to resurrect some way that those tariffs can be made of benefit. And people are asking, well, if you've no tariff, no incentivisation, do you have to bother with the standards of care within the specification? And I said, of course we do, because that's internal motivation. We've got to offer the best care. So we have to stick out for delivering what's on the tin, whether we have the money or not. And we've got to make the case to take money from within your hospital service, even though the tariff isn't ring-fenced. Okay, the money will be there because it's part of the contract, but it just doesn't have a nice perimeter around it that says only for diabetes use. So there's money there. The pounds and pence are on the bottom right-hand corner, but we need to fight hard as clinicians to get it utilised in our service. So it's not lack of money, it's lack of ring fencing. Yep. Yep. And we've all got a bit of that, but we never give up because we've got to keep going at it. And every other day, I'm in the office with my business manager saying, right, come on, how about what's going on now? You've got to work at it. It's actually somebody's job in the units these days to try and get business cases written and funding into the team. It's hard work. There's no other way at the moment, but there may be in the future. Does that make sense to everyone? Yeah. We haven't got time to chat.
We haven't got time to chat. I was just imagining what it must be like to say no to you for money in your trust. I would not like that job.
I've been told no, but it's not quite as I like it. But,
Yeah, well, we have overrun on the programme a little bit. We've missed our table work session. If you are watching online, I would love you still to be able to complete the Mentimeter. If you go to the Mentimeter link at the bottom of where the video is. We wanted to finish on a positive, really, which is to think about what are the most rewarding aspects of providing paediatric diabetes care. Because one of the things that is clearly an issue is staffing. Staffing in units, that's a common theme that keeps coming back, but we're also hearing that often funding will be found for a role, but there's not necessarily a specialist that can be put in place, or there aren't enough specialists for the roles available. So at the last national network meeting I attended, someone suggested, we need a recruitment drive. We need a recruitment drive for paediatric diabetes. And so, I don't know, maybe it'd be worth thinking before we go, because we've got 15 minutes. This is closing remarks and final reflections. I'm in your spot now. We've run into yours. But just to think about why paediatric diabetes care? Why do you do this and not something else? It's got one drug, a couple of technologies. What? It's true, though, isn't it? And, well, no, of course, it's clearly not. But, compared to other specialties, why are you doing this? Have I just lost my job? Justin says it's got people. Yeah, it does. Oh, you're doing it in the room. Bless you. I mean, we could just collect your written comments. But yes, is it possible to put the...
Oh, dear.
Amazing. Is it there in the chat? Is the code there? Oh.
Can you all stand up?
Just...
Do you want... I'm on the way. Hang on, I'm getting out of here. Let's stand me by the stage.
Excellent. Yeah, I want to see what people have said to this. It's the old one. Tasha, if you could move it forward. Yeah, apparently the old one is up there. Tasha's just moving it along now. Okay. Yeah, RCPCH had a really, really successful campaign called Choose Pediatrics. So, choose diabetes. Who's going to lead on that, Fiona? Is there going to be a working group on that?
Younger bottles than me, for sure. So, I don't know what we do. I'm interested to see what people say, actually.
I'm interested to see what people say. Sorry, everyone, we will get the link up very shortly. And while we do that, I just wanted to say, if you are interested, Justin's always threatening me with retirement, and it's one of my biggest professional anxieties. Well, yes, you are semi-retired, and the thought that one day you will be actually retired is one of my biggest professional anxieties. So we need to start thinking about succession planning. Justin has very kindly said he'd do a transition. So if you're ever interested in being the clinical lead of the NPDA, which is, I think, a very rewarding job, please do speak to Justin, have a chat about it, see what it entails. It's a paid role. We'll pay your trust for your time. But yeah, have a chat to Justin. Okay, can you log in on mine?
So, will I reflect while we're doing this?
Yeah, Fiona can reflect while we're doing that. Thank you.
So, in order not to hold everyone up, we are going to get this for sure, but just a few reflections, and I'll finish my bit so we're not held up. And then at the end, your parting comments to us, you can reflect using the QR code if we find it. So spent the day together. It's been a fantastic day. I think it's a great day for bringing everyone together with the data theme in mind. And it illustrates how hard the team work, both locally to get the data and to send it, and the team to analyse it, wash it down, and then present it in an understandable format. So it's a really, really excellent audit, but only excellent because we have everybody participating and everybody seeing the value. So great thanks to Justin for bringing it all together, because in some respects, Justin's presentation actually shortcuts the need to really read all the detail. But what I would advise you to do is please use your own local reports to influence your discussions to get investment in service. So that is really, really important. We heard from Reinhard, obviously an international collaborator, an endocrinologist like some of us in the room, but also got an interest in data to drive improved outcome. And it's very interesting to compare our performance, if you like, in terms of processes and A1C with our international colleagues. We can't be too blinkered and always just look down and in. We've got to look up and out so we know what we're comparing with. And really, the other side of it is actually Emma had come along to tell us about marginalisation. And we know a lot of this, but it's actually pulling it back and saying, remember, remember, remember. And we learned even more from Sanjay's presentation about trying to include marginalised populations and everybody who can be challenged with poverty at the moment when the cost of living is so high. So we're tying in those themes of just thinking that not everybody is as privileged as we might be sitting in the room. And then in the afternoon, we had great presentations from patients, from the forum, from Andrew, who was here. Fantastic young people, experts by experience, giving us their advice about how we can improve our services. Also illustrating how the adults and the young people's teams in paediatrics can come together to have a seamless 16 to 25 service. So that's the way to go. And if we can all emulate what we heard from your hospital, then we would all do really, really so much better. And once again, a plug for the Together Type 1 programme. Please try and use that resource in your communities to bolster your own workforce. Because we're sitting here saying we're short of people in the workforce. But actually, there's the third sector. There are community volunteer groups that we're not really utilising. So let's try and get them in there to try and really help us along with the work that we do every day. And then it was Holly doing her summary, telling us about what had been achieved and what's to come going forward. So we've got a lot of things to be very, very optimistic about as far as our data. And remember one other thing, I know data is hard to collect. I know we've been tasked with another job for hybrid closed loop, but we're the first country in the whole world to suggest that, or mandate actually, within a time scale, that all young people below at 18 and below should be managed or offered hybrid closed loop. So that is the most amazing achievement for our community over several years of research and bringing, bench research to bedside and mandated use, really. So let's moan about it, because we always do, but let's really think about the benefits to our young people with the ability to do this going forward. So well done. Holly, have we got it?
No, due to technological meltdown, some hardware issues, we haven't. We're going to send it out in our next com, though, because I think I really do want to collect this information, and I think maybe we can just put it on the front cover of our workforce audit report as well. Why paediatric diabetes?
And what we do.
Choose paediatric diabetes,
right.
yeah. We'll do something with that.
Yeah. Very good. That's
Yeah.
great. So I think it's time for dismissal of the audience. Big thanks to everybody, particularly the college team, particularly our helpers over there in IT, and particularly to our contributors and all the hard work getting ready to go.